All right. That is great. You guys can hear me? Awesome. So today what we're going to do is we're going to start CNS. Okay. It is one of the largest chapters in first aid. But we will try to tackle it in a way that it's going to be beneficial for all of you guys and people who watch this. So let's just get into it. All right. The first thing that we talk about here is, of course, the embryology, right? So let's get into that embryology. So neural development. Okay. So it starts from here. So notochord induces. So take a look at this. This is the notochord. Okay. It induces the overlying ectoderm, which differentiates into two things: neuroectoderm and from the neural plate. Notochord becomes what? Nucleus pulposus of the intervertebral disc in adults. Neural plate gives rise to neural tube and neural crest cells. Okay, so what did we talk about till now? So we said, let's just do it here. We said this guy, notochord is inducing the surface ectoderm. So let's just say ecto here, ectoderm, right? And that ectoderm is going to it's going to differentiate into neuroectoderm, and that will form neural plate, right? And that neural plate will give rise to two things. It will give rise to neural tube and neural crest cells. So let's look in the picture. Where do we have neural tube and the neural crest cells? Okay, now let's look at the next point. That is the lateral walls of the neural tube. Specifically, they're looking at this guy, neural tube, are divided into alar and basal plates. Okay, so alar plates, which are dorsal, they form sensory. They're induced by bone morphogenetic proteins, BMPs, and the basal plates, which are ventral, they are motor. So let's just look at this as well. So you have the alar, which are dorsal, but they're sensory. Basal, which are ventral, which are motor, which is induced by Saanich hedgehog, SHH. Okay, it is the same orientation as the spinal cord. Okay, so now just look one more thing here, that this neural tube is going to form two things then. What is it going to form? The neural tube is going to form the walls of the CNS, which is mentioned right here, and it will also form. So let's just go back one thing. So when you form the walls, right? Let's say these are the walls. You're going to form some lumen. Lumen is the inside part, right? That lumen is going to form something too. So you have a wall, which are these, and there's a lumen inside, and that lumen is right here, which is going to form the ventricles plus, and it's going to come up in the next section, but it's just to it's a very simple thing to understand here. Lumen will form ventricle because it's a hollow space, and the spinal cord canal. Okay, now just let's review the whole thing and let's move on to the next review. What are we looking at? We said notochord is going to induce the overlying ectoderm, which is right here, the top layer. This is the ectoderm. It's going to induce that ectoderm into formation of neural plate. That neural plate, and what is going to happen to notochord itself is going to be intervertebral disc in the adults. That's about it. And these neural plates, then what are they going to do? Well, they will then form neural tube and neural crest cells. Two things. What is neural tube going to do? Let's just put it here. We have the walls of the neural tube and the lumen. The walls are going to form the whole CNS, central nervous system, and the lumen is going to form all the open part which is the ventricles and the spinal cord canal. And what about these peripheral neurocrystals? Well, these are going to form all of the peripheral nervous system, PNS, and that's all about it. Two things that you have to just remember: that the alveolar, which is sensory, will be induced by BMPs, and the basal plate, which is motor, is induced by SHH, which is Saanich hedgehog. Okay, so let's move on to the next one. What do we have? All right, here we have the regionalization, very high yield, super high yield. Okay, regionalization of the neural tube. Here we have the telencephalon is the first part. Let's also take a picture. Take a look at picture here. This is right here, telencephalon. Diencephalon, simple high yield thing. Di means two, so two things. Diencephalon is the second part, so two. Second, the rest are arranged alphabetically. So we have the mesencephalon, metencephalon, and myelencephalon. So all you have to just remember is, if you look back here, we said the walls are made and the cavity, which is the lumen, is made, right? And these whole thing is just made by the neural tube, right? So the walls and the cavity. Here, if you look, the forebrain, which is known as prosencephalon. The next midbrain is formed, which is known as mesencephalon, and rhombencephalon, hindbrain. I wish I have a mnemonic on this, but all you have to just remember is the pro is at, whoever is pro is going to be at the top. So pro is at top. And this rhomben, just think about a rhombi shape sort of a deal here. So you can think about rhombencephalon at the bottom. So the only thing that is in the middle is mesencephalon. More than this, what is important is these structures. And here you have the telencephalon, the first one. So just think about T as 1, di you already know is 2. Then you're left with mesen and meten. Mesen, meten, myelin, right? So you can, the mnemonic that I have, I mean, if you have a better mnemonic, for sure, just share with me. I'm happy to hear that. So, but what mnemonic you can have is messy met myelin. So Messi met myelin. So if you don't know, Messi is a football player. He met Myelin. Myelin, she's a beautiful lady. Okay, that's how we can go with it. And for the top ones, Telin is like 1 and Dine for 2. So let's just recall this thing. So you have the telencephalon, diencephalon, then Messi gonna be here. Then he's gonna meet what? He's gonna meet myelin. So here you go, all of that. So now let's just look at the 5 secondary ventricles that form. So the telencephalon, it gives rise to which walls? The cerebral hemispheres and the basal ganglia. Okay, and the diencephalon is going to give rise to thalamus, hypothalamus, and also retina. Meson, if you look here, it was also midbrain, so it's going to give rise to midbrain. That's simple. And for the hindbrain, you just have these structures in there. You have the pons, the cerebellum, and the medulla. So the meten and myelin are going to form, well, actually, meten is going to form the pons and cerebellum, and myelin is going to form medulla. But it's way easier. It's way easier if you just look at the head and say, okay, we have cerebral hemisphere. That should be the top. Then we have a basal ganglia. Okay, coming down slowly, we have a thalamus, then get hypothalamus, retina. Okay, keep retina over there. On top of that, you also have a midbrain. Right now, you're just coming down from top to bottom anatomically, right? You got a midbrain. After midbrain, you got pons, then cerebellum, and medulla, right? So these are how you could just memorize normal anatomical structures and just say, okay, the first one is going to give you the top, second, the mid one, third is the midbrain, and fourth is about the pons and cerebellum. and the myelin is all about medulla. Same thing goes for the cavities, which is the ventricles. What is the first ventricle that you're looking here? The lateral ventricle. So you have two lateral ventricles here. Then you have one third ventricle. Third ventricle is going to drain via cerebral aqueduct to that's going to be your midbrain, right? After cerebral aqueduct, you have the upper part of the fourth ventricle and lower part of the fourth ventricle. But this, for sure, this will come up later on as well, and you will be able to tell after that. But what is important in this high yield point is all about the names, the structures, the main structures, which are your telencephalon, diencephalon, mesencephalon, forebrain, which is prosencephalon, mesencephalon, and ramencephalon. Okay. So yep, that's all we have for regionalization of the neural tube. Let's look at the next one. What do we have? So now we have the central and peripheral nervous system origins, high yield. So neuroepithelia in the neural tube, CNS neurons, gives rise to CNS neurons, CNS glial cells. What are the glial cells? They're the astrocytes, oligodendrocytes, and ependymal cells. And we will talk about all these cells coming up in anatomy. Second thing is all about neural crest cells. So the neural crest cells, they give rise to the peripheral nervous system neurons, in which you have a dorsal root ganglia, autonomic ganglia, which is sympathetic and parasympathetic, right? And PNS glial cells. What are the PNS glial cells? The Schwann cells and satellite cells, and also give rise to adrenal medulla. Mesoderm is a microglia, which is like macrophages. So looking at the whole thing in perspective, we said that we have the walls, right? We said we have a wall, and that wall of that tube. So this is the, let's say, for example, let me just erase this. So this is a wall. It forms a tube, right? Because here's the lumen. So that wall of the tube is the basically neural tube, which gives rise to CNS neurons and the CNS glial cells. Or majorly, you can think about CNS. And the second thing that you're gonna think about, so you had some cells on the sides, and I'm gonna go back to the picture above, and we will see that. And those cells on the sides were known as, if you look here, let's just erase this. So you have a neural tube. You can see, let's just zoom in so you can see in a good way. Look at this. So this is the whole wall, right, of the neural tube. Here is the lumen, right? And here is the peripheral cells, which are known as the neural crest cells. So going back here, those neural crest cells, these ones right here, neural crest cells are going to give rise to the PNS, peripheral nervous system, right? And here's what is, here what it is. So you had these peripheral cells, and they are going to give rise to the neural crest PNS neurons. The word is peripheral nervous system, which is important. And the lumen of the tube will give rise to, as you already know, the ventricles plus the spinal cord canal. And that's all about it. And if you look at this one, this is mesodermal origin, microglial, macrophage, or mesodermal high yield. Or mesodermal, microglial, or the mesodermal origin, like macrophages. And that's all about it. So let's just recall this thing and then move on to the next one. So we said the neuroepithelial cells in the neural tube are going to give rise to CNS neurons, right? CNS. What do we mean by CNS? Well, we said CNS. CNS means it has CNS neurons and the glial cells of the CNS. What are the glial cells? They are the astrocytes, they're the oligodendrocytes, and they're the ependymal cells, right? On the other hand, the crest cells, the neural crest cells, which are on the periphery, right? these are going to give rise to PNS, peripheral nervous system. In which case, what are the peripheral nervous system cell things that PNS neurons give rise to? Dorsal root ganglia, autonomic ganglia. So all your sympathetic, parasympathetic is what? Peripheral nervous system. On top of that, you're looking at some Schwann cells, which are the glial cells of the PNS, and satellite cells and adrenal medulla. One thing which is not from the wall or the periphery is the mesodermal macrophages, which are microglial cells. And that is all. Let's move on to the next high yield topic, which is neural tube defects. All right, now let's talk about neural tube defects. Well, neural tube defects is the failure of the neural tube to close completely by week 4 of development. It is associated with maternal folate deficiency during pregnancy, high yield. So folate deficiency in pregnancy causes NTDs, neural tube defects. How do you diagnose this? You can diagnose it by doing ultrasound, maternal serum AFP levels, and also one more thing that you can see is acetylcholinesterase levels, ACHE. Acetylcholinesterase acetylcholinesterase levels, right? Yeah. So these things can be seen in the maternal serum, like AFP and ACHE. So now let's talk about what's really happening here, right? So when you have the failure, so here is specifically for these spinal problems, we are looking at the failure of the caudal neural tube to close. So what's going to happen is when these are also, you will see they might say neuropores to close. Neural tube, caudal neural tube to close, neuropores to close. It's going to cause NTDs, which is neural tube defects. Here, then what's going to happen is, so when you don't close, let's say this is the spinal cord at the end, at the caudal part, right? And you can't close it. When you can't close it, what's going to happen is you will leak out. There will be leakage of the AFPs, which is alpha fetoproteins AFP, and there will be leakage of ACHE. Okay, where? In the amniotic fluid. In amniotic fluid. So, and that from this amniotic fluid, what's going to happen is that these things will cross the placenta and get into maternal circulation. When they get into maternal circulation, and so you check the maternal serum blood, meaning check maternal blood, in the serum you will find AFPs and ACHE, and that say, hey, what are they doing here? Well, they're here because there is the opening of the neural tube. Okay. And how do you you could also check these things in amniotic fluid, by doing aminosynthesis. And that's the whole thing. So now let's just look what diseases it can cause. So we have the spinal dysraphism. Okay. So simple words, we have the spinal bifida occulta, meningocele, myelomeningocele, and myelocystis. Okay. So let's just take a look at this picture. So if you look at all the ending is seal, right? And the next one is just schissus. So if you take a look in this picture, this is the normal picture, right? Let me just go up a little bit. Okay. So in the normal picture, we have the dura mater, we got the leptomeninges, which is the arachnoid and pia, arachnoid matter and pia matter. And we have the spinal cord within all of these layers, right? And it is closed by this bony this bone, right? It is closed, and you have the nice normal skin up top. Now let's look at the spina bifida occulta. Occulta basically means that you have just an opening, but there isn't. The neuronal tissue is not out yet. There is just an opening. There is just an opening. Okay. On top of that, with an opening, because it's an abnormality, right? So you can see some tough hairs or skin dimple. Okay. Now let's talk about meningocele. When you say seal means that some neuronal tissue is out of that bony abnormality. So here, what is out? So if you look here, so you have in meningocele. Let's look here. Meningocele, open meninges. Meninges are out, but not the neuronal tissue. So if you look at the neuronal tissue, it is not out. So spinal cord stays here, but what is out is the meninges are out. The meninges are out, right? But in myelomeningocele, everything is out. You have the spinal cord. So if you look up top here, it says you have the meninges plus the neuronal tissue, which is spinal cord, which is also out, causing cord equina syndrome. We'll talk about that. Hernia through the bony defect. So just to recall the whole thing, what it is spina bifida occulta. It's gonna have tufts of hair, dimple on the skin, with just a bony abnormality. No meninges, no neuronal tissues out. Seal is when you have meninges out. So look, meninges, seal out. Meninges are out. Neuronal tissue, meninge plus meninge, seal out. All of them are out. Okay, so as the name gets bigger, it's getting more and more problematic. So now let's just read that up top and move it on to the next. So what do we have? Spina bifida occulta. We have the closed entities, meaning it's a closed neural tube defect. So what I deal with this is because it's a closed defect. What are we talking about? We said if you have an open defect, your AFPs will go out from here all the way into the blood, right? But since it's a closed neural tube defect, and you can see here, nothing came out, so you have a normal. So in this case, you will have a normal AFPs. Okay. You have a failure of the caudal. We talked about caudal neural tube to close, but no herniation, high yield. Dura is intact. Usually seen at the lower vertebral levels, associated with tuft of hairs, important tuft of hairs or dimple at the bony defect. Okay, the second one is about seal, meningocele. So meninges are out from the defect, and it is open. What it's going to cause is going to cause AFP to be high and also AACHE to be there. Myelomeningocele, myelomeningocele, three things. So actually two things out, right? So meninges, neuronal tissue are out of the bony defect. Now myeloschisis, this is just exposed. So if you were to take a look, I mean they don't have a picture here, but if you were to take a look here, you still have skin, right? So if you had the skin dimple, here you had the skin thinning defect, here you also had either skin thinning or absent. The next thing you don't even have a skin. So all you have is just the spinal cord, the whole neural tissue just out. And that is your myeloschisis, which is exposed, unfused neural tissue without skin or meningeal covering. So it doesn't even have the meningeal covering. The whole neural tissue is just out. Okay. And that is what we have. Now, here, what we also are going to see is that these two things will present as, because you see that you have some sort of, let's actually erase this. These guys will present as a cyst. So these two guys are going to present as cystic mass at the lower vertebral level. Cystic mass. Okay, that will be seen. So what is the well? Actually, let's do anencephaly and then we look at the easy treatment option here. So now let's look at what happens. So this was all about caudal part, right? What happens if you have the rostral neural pore to close? If you have the failure of the rostral uh, a neural tube to close. So if you have that, what is going to happen is the patient would develop anencephaly. It is again an open entities, meaning you will have AFP and ACHE will be present. There is a failure of the rostral neural pore to close, leading to no forebrain, open calvarium, often present with polyhydramnios. Why? Because there is decreased fetal swallowing due to lack of neuronal control. So you don't even have a center of swallowing, so you can't swallow. When you can't swallow, you're gonna have polyhydramnios, right? Because one of the things that keeps the amniotic fluid in level is that the baby it drinks the amniotic fluid and pees it out. But when you don't even have the swallowing center, you can't swallow it. It's gonna cause polyhydramnios. High yield, no forebrain, open calvarium, polyhydramnios, and anencephaly is the rostral neural pore to close, the failure of the rostral neural pore to close. Okay, take a look at this picture of anencephaly. So we said there is no forebrain. So it's like a frog-like appearance. Okay, open calvarium and polyhydramnios. Where the rostral neural pore, there's a failure of the rostral neural pore to close. And that's all for this picture. All right, now with this, what is the treatment? Not treatment, but prevention, basically. Here, if the prevention is going to be, you could have the patient who is pregnant or who is trying to get pregnant. Actually, it's recommended for all women of childbearing age. So it doesn't matter the woman wants to become pregnant or not. Any woman of childbearing age, you can they must have a folate supplementation. Folate supplementation which is vitamin B9. Folate supplementation is mandatory on them. And that is all we have. So let's just review this and move on to the next. Let me erase all of this. All right, so we talked about neural tube defects. Neural tube, when the neural tube does not close either caudally, and what is caudal? Caudal is, so head, let's say this is the head. Head is about rostral. So let's just put it here. Rostral is like head, or is also known as cephalic, towards the head, towards the head. Rostral or cephalic. Caudal is towards the lower vertebral column, let's say, or not the head, opposite to the head, or the caudal side, which is towards the end of the body. And the other let's just talk about them as well. You have the posterior. Posterior is also known as dorsal. So dorsal skin, yeah. And anterior is all about your ventral. So this is just a terminology. But how you'll hear we were talking about rostral and caudal. So caudal here is all about the spinal cord, the peripheral, the lower vertebral column, which is the caudal end. So in the caudal neural tube fails to close by 4 weeks, you're gonna get neural tube defects, which are all of these. And you could check that out by doing an ultrasound, by maternal serum AFPs, or you could actually look in amniocentesis by looking at AFPs or ACHEs on in the amniotic fluid. So the occulta is the very benign one, meaning very least problematic. And this is all about it is a closed entity, so it's going to have a normal AFP levels, and you will just have no herniation, just tuft of hairs and the bony defect, and with skeleton dimple. Myelocele meninges are out. Meningocele meninges are out. Meningocele neuronal tissue meninges are out. Myelocysis, neural tissue is out without any covering on top of it. And that is all we have for the caudal ones. And the rostral ones, if there is a failure of the rostral neural pore to close, you will have anencephaly, which is no forebrain with polyhydramnios. The no forebrain is going to look like a frog-like appearance. Okay, and prevention, folic acid, supplementation to women, all of childbearing ages. Okay, and that is all for this one. Let's move on to the brain malformations. Brain malformation is often incompatible with post-natal life. Survivors may be profoundly disabled. So we have, the first thing we have is the holoprosencephaly. As the name suggests, there's holo. What was prosencephaly? It was the forebrain, right? If you just look back here, prosencephalon is what is the forebrain. So holo, 1, prosencephaly, 1 forebrain. Okay, so failure of the forebrain, which is the prosencephalon, to divide into 2 cerebral hemispheres. So developmental field defects usually occurring at week 3 to 4 of development. It is associated with SHH, Sausage Hedgehog mutations, may be seen in Patau syndrome, high yield Patau syndrome, trisomy 13, and fetal alcohol syndrome. Okay, how is this patient going to present? It's going to present as midline defect. 1 ventricle, which is monoventricle, picture A, fused basal ganglia, cleft lip or palate, hypothalamus, cyclopia, presbycusis, increase risk for pituitary dysfunction, diabetes insipidus. What is hypothalamus? Hypothalamus is small distance between eyes. So you have a very small distance between eyes, is known as hypothalamus. What is cyclopia? Cyclopia is with just one eye. You don't even have 2 eyes, you just have 1 eye. Or proboscis, and this is nose defect. Okay, so all you just have to think about in holoprosencephaly, that this whole thing in the midline structures are all out. So you have a cleft lip palate, fused basal membranes, basal ganglia, monoventricle, cleft lip palate, hypothalamus or cyclopia, and proboscis. Increased risk of pituitary dysfunction, which is going to lead to diabetes insipidus. And why this happened? Well, it happened because a patient might be having Patau syndrome, which is trisomy 13, or fetal alcohol syndrome, which is associated with SHH mutation, Sausage Hedgehog mutation, and these patients will have a field defect. And what else? And one of the also thing that we're not talking about here is, we said there's a failure of the forebrain, right? Prosencephalon. But what actually forms these cerebral hemispheres? So prosencephalon will mess up the formation of telencephalon. Telen was, again, if you recall, T for 1, right? So the first thing, so let's just take a look at that picture. Here's what I'm talking about. The forebrain is going to give rise to telencephalon, which was going to give rise to cerebral hemisphere. So we said we only have one hemisphere instead of having two. So where's the problem? Telencephalon. They might not mention the prosencephalon, and you be thinking, hey, if it's hollow, you are prosencephalon. But no, you got to say, okay, what prosencephalon is going to give rise to? Telen and dine. So you could have any of these problems, right? So take a look at prosencephalon, telen, and diencephalon. These two things are going to be affected when you affect the prosencephalon, and that is a high yield point. So here's in the hollow prosencephaly, although you have a problem in the prosencephalon, but one thing that is going to be messed up is your telencephalon high yield, associated with Patau syndrome high yield. Okay. The next one is you have lysencephaly. Lysencephaly. So lysencephaly is the failure of neuronal migration. Which causes smooth brain surfaces that lack sulci and gyri. Picture B, look at here. Is the smooth brain without sulci or gyri, right? So we have a smooth brain that lacks sulci and gyri. One of the mnemonic that you can have is, you can say garlic, right? So garlic in my language we call it lesson, yeah. I don't know if you guys can, but lesson is like garlic. So just remember, this is garlic. This is my mnemonic. If you have any mnemonic, you're most welcome to share, and we'll definitely go with that. But lysen is like lesson. Lesson, it's not lesson. I don't know how to spell that, but it's garlic basically. So when you think about garlic is pretty smooth, right? Pretty smooth guy. So lysencephalon is smooth brain without any sulci or gyri. It's simple. Okay, it's going to present with dysphagia, seizures, microcephaly, and facial abnormalities. So all you have to just think about, okay, because you have a smooth brain, it is going to be small, microcephaly. It can lead to, it can lead to seizures, dysphagia, and some facial abnormalities. But what is important is why this happened. It happened because there was a failure of neuronal migration. So neuronal tissue couldn't migrate, causes smooth brain that lacks the sulci and gyri. Lesson is garlic is smooth is brain which has no sulci or gyri. And also let's review the top portion. That is your hollow prosencephaly. Hollow is one forebrain that did not divide. When you didn't divide that, you have a problem in telencephalon. First of all, you have a problem in prosencephalon. That leads to a problem in telencephalon. And why that division didn't happen? Because there was a problem. There's a mutation in SHH seen in Patau syndrome high yield, and you can also think about fetal alcohol syndrome. It's going to present as a midline defect. Midline, whatever the structures of midline, they're going to be defective, which is one ventricle, fused basal ganglia, cleft lip palate, hypotelorism, cyclopia. Hypotelorism is two eyes close together. Cyclopia is just one eye. And presbycusis is a nose defect. In pituitary is also central midline, right? So you can have a pituitary defect as well. And these are all for the brain malformations. So one thing extra for neural tube defects, as we said, the neural tube defects are due to the fact that you have a folate deficiency, right? So it doesn't really matter that a woman, one of the things is a woman isn't taking folate, right? That's one major thing. But the other thing is a lot of time that's not the case. The case is different. That the woman who is at the childbearing age, she takes some other medications which mess up the folate metabolism. What are the medications which would inhibit? First of all, the dihydrofolate reductase. So those are your methotrexate, MTX, sulfasalazine, ampterine, and trimethoprim. Okay, so these medications will mess up the folate metabolism, causing neural tube defects, especially in the first trimester. And what other medications could be which would inhibit the folate metabolism are going to be your valproate, which is valproic acid, carbamazepine, and phenytoin. So these also they inhibit the variable inhibition of folate metabolism by these drugs, and they also lead to folate deficiency. So anything which causes folate deficiency, especially in the first trimester, with these drugs causing problem in the first trimester, leading to folate deficiency, causing neural tube defects. And just wanted to add that, and let's move on to the next topic, which is posterior fossa malformations. So in posterior fossa malformations, we have the Chiari 1 malformation and Chiari 2 malformation. So Chiari 1, as the name suggests, there's only one thing. So let's read and we'll see what I mean by that. Chiari 1 is the downward displacement of one thing, and that one thing is called cerebellar tonsils through the foramen magnum, right? So if this is the foramen magnum, what is going to herniate in Chiari 1 malformation is just the cerebellar tonsil to the foramen magnum. Okay, one structure, Chiari 1. Usually, it is asymptomatic in childhood, manifests in adulthood with headache and cerebellar symptoms. It is associated with spinal cord cavitations, which is Syringomyelia high yield. So because you're pushing on, let me just look at this picture. You're pushing on this on the spinal cord, causing this syrinx formation, which is a cavitation within the spinal cord, and that is known as Syringomyelia. And we'll talk about that in the next section here. While in the other way, we have this second disease, which is called Chiari 2 malformation. Chiari 2 malformation, it is the downward displacement of two things. One, cerebellum. And cerebellum has two things, right? Cerebellum has a tonsil and a vermis and the medulla. So two major structures are going to be herniated down through the foramen magnum. Okay, it leads to non-communicating hydrocephalus, which is more serious than the Chiari 1. So that is why it's going to present early in life with dysphagia, stridor, apnea, limb weakness associated with meningeal, neuronal tissues out, meninges are out, seal they're out, usually lumbosacral, high yield. So associations are high yield. 1 is associated with Syringomyelia. 2 is associated with two things also out, myelomeningeal seal. Two things also out, cerebellum, medulla, right? And that is what we have in these two things. Because the 2 is more serious, so it's going to be in childhood, it's going to be present early in life. 1 is not that serious, so it's going to be asymptomatic in child. But as the patient grows old, in adulthood, you're going to get these headaches and these cerebellar symptoms. Okay, and with the 2, all you're getting is first of all non-communicating hydrocephalus, high yield. Okay, and it's gonna cause dysphagia, stridor, apnea, limb weakness. Okay, so we talked about these two things of the cerebellum. Now let's talk about one thing, which is the midline structure, which is known as vermis of the cerebellum. So that is the Dandy-Walker malformation. So Dandy-Walker malformation is basically you have the agenesis of the vermis, cerebellar vermis, which leads to cystic enlargement of the fourth ventricle. So just imagine that you have in the center you have the vermis, right? When you don't have the vermis, something is going to take over. That's just normal thing. And in this scenario, who's taking over is just the fourth ventricle. Is taking over. Look in the picture B. Here's the B. You see this is fourth ventricle taking over here, taking over the vermis area, cystic enlargement of the fourth ventricle that fills the posterior fossa. It is associated with non-communicating hydrocephalus. So same thing as above, non-communicating hydrocephalus, and spina bifida, which is the least problematic spinal defect, spina bifida. Okay. And that is what we have. So with this, what you are going to have is, let's actually do this here, non-communicating hydrocephalus. On top of that, you already have a non-communicating hydrocephalus, right? What is giving you that non-communicating hydrocephalus? Because we said that you have, there is gonna be atresia. This is point. There's gonna be atresia of foramen Luschka and Meninges, and we will talk about what foramen Luschka and foramen Meninges is. But here, just remember that you have the atresia of these two foramens, which causes these hydrocephalus, which causes the CSF to not move forward, causing non-communicating. There is no communication of the CSF because you have the atresia of two foramens, foramen Luschka and Meninges. But what about this top one? Why do we have non-communicating hydrocephalus up top over there? That's due to the fact that you have aqueductal stenosis. It's because when the medulla and cerebellum went down, you have the cerebral aqueduct between them right here. So that just pushes on the cerebellum. This aqueduct causes aqueductal stenosis, and we will talk about this as well, and you'll see what that aqueduct is later on in anatomy, I think. So yes, and that is going to present with, because you are also messing with the medulla, you are going to present with all of these things like dysphagia, stridor, apnea, and limb weaknesses. All of that is there. Okay. And here, what we will see for Danny Walker is going to be infant. So this patient is going to be presenting with infant. Infant is going to present with enlargement of skull, enlarging skull. Right, one thing. Second thing is that enlargement of skull is going to cause increase in intracranial pressure, which is going to irritate and cause profuse vomiting and vomiting. Okay, so let's just review this whole thing and move on to the next. So what did we talk about? We said we had the posterior fossa malformations. Carry 1, carry 2. 1 means one thing is out, which is the tonsil, cerebellar tonsil. Okay, one structure is displaced downward. When you displace that structure downward, you are going to mess up the spinal cord itself, which is going to form the cavitation within the spinal cord known as Syringomyelia or syrinx. Okay, and also because you're messing up with the tonsil, you're going to have a cerebellar problem for sure. But this is just a very minute thing. Only one thing is coming down. So in a child, it's going to be pretty normal. But adult is going to manifest the problems. Where the two is two structures coming down, which is the cerebellum, which is the vermis and the tonsil, the whole cerebellum, vermis and the tonsil, right? And the medulla. When these two structures come down, you are going to form a non-communicating hydrocephalus. And that non-communicating hydrocephalus is simple due to the aqueductal stenosis. But high yield point is associated with two things, right? We said cerebellum and medulla. So two things are also going to be out at the lumbosacral level, which is meningocele. The neural tissue, the meninges, both of them are going out in the lumbosacral region. These patients will present as a child with a non-communicating hydrocephalus with dysphagia, can't swallow, stridor and apnea, and limb weakness. With the Dandy Walker, Dandy's a kid. Dandy's an infant who walks on the wormus. You know when the moon walks on. So Dandy's a kid who walks on wormus. Wormus is like a vermilion butter, I guess. Moon something, anything you call it. Um, so Dandy Walker is a child who walks on the wormus. When you walk on the wormus, you're gonna call what? You're gonna cause it agenesis of it. You can destruct that, lead to destruction, not destruction, but not formation. By the same proper wording here is agenesis, right? But just a mnemonic here is Dandy Walker is a kid who's walking on wormus. Wormus is the main problem here. So there's the agenesis of the wormus, which causes enlargement of the fourth ventricle that causes non-communicating hydrocephalus because there's atresia of the Luschka and Meninges, and it causes spina bifida. If the top one is causing is myelomeningocele, this guy's going to cause spina bifida. On top of that, this kid is going to come as enlargement of the head, with enlarging head. You'll be like, what's going on here? Well, enlarging the skull is due to the fact that you have this fourth ventricle getting enlarged. Let me look at this picture. Enlarge, because you have atresia. There's a non-communication. So all the fluid is just going to come here and it's going to enlarge. That's going to increase ICP, causing irritation, causes vomiting with the child. And that is all for the Dandy Walker. Let's look at the Syringomyelia. Syringomyelia. Well, Syringomyelia is fluid-filled. What fluid? CSF. Gliosis lined cavity within the spinal cord. Looking at picture A, yellow arrows. So this is all the cavitation. Okay, and that cavitation, it has a fluid because it's a cavity. The fluid is going to be there, which is going to be the CSF. Okay, fibers crossing in the anterior wide commissure, which is the spinothalamic tract, are typically damaged first, which leads to cape-like loss of pain, loss of pain, temperature sensations in the bilateral upper extremities. Looking at the picture of this, here what we have is we have cape-like loss of pain, temperature. Why? Because we are messing up the anterior wide commissures. What goes through that is the spinothalamic tract. So the easy way to think about it is Syringomyelia. S for Syringomyelia, S for spinothalamic tract. Spinothalamic tract. Problem with the spinothalamic tract, SNS, right? And the spinothalamic tract is going to be PT out. What is PT? Pain is out, temperature is out. Pain is out, temperature is out. In the cape-like distribution, okay. Okay. And as a lesion expands, so this lesion, which is right here, is going to expand, right? It expands, it may damage the anterior horns. And when it damages the anterior horns, it's going to cause lower motor neuron deficits. And what are the lower motor neuron deficits? Well, the lower motor neuron deficits are going to be your flaccid paralysis. So the patient will come with flaccid paralysis, atrophy of the intrinsic muscles of hands, flaccid paralysis, and the atrophy of intrinsic muscles of hands. Okay, and syrinx is a Greek which equals tube, as in syringe. Most lesions occur between C2 to T9, usually associated with Chiari 1 malformation. We did say one problem. One is the syrinx, right, which is red arrows in A. So you can see you have the tonsil herniating downward, causing cavitation opening within the spinal cord, leading to cavitation within the spinal cord. and that cavitation gets filled by the fluid, which is the CSF. Okay. Less commonly, it is also associated with other malformations, infections, tumors, or trauma. Okay. One of the high yield pointed to this Syringomyelia. It is not associated with MS, multiple sclerosis, and we said here, we just talked about how if it was to mess up the anterior wide commissure, we can have a spinothalamic problem. If it was to damage the anterior horn, we can have a lower motor neuron deficit. The third thing, which they haven't mentioned here, is going to be if they mess up the lateral horns. Because slowly and gradually it's just going to increase in size, and it slowly and gradually is going to mess up more and more. So when you mess up the lateral horns, that is going to give you Horner syndrome. Horner syndrome is, if you look here, let's take a look at this thing. So you have syrinx. This is the expanding of syrinx, right? So as the syrinx is expanding, the first thing it's going to mess up is this anterior wide commissure, right? And anterior wide commissure has, look at these, there's the spinothalamic tract going through the anterior wide commissure, right? So when you mess up the anterior wide commissure, you're going to mess up the spinothalamic tract, which is the pain and temperature. But this thing is growing. This is not going to stay there. So when you expand this, you're knocking out what? You're knocking out your spinothalamic tract, which is the first thing that you see. Now, the second thing that you see is when you damage the anterior horns, that's going to mess up the that's gonna give you a lower motor neuron deficits. And when you mess up, when this increases and causes the lateral horns, expands and messes up with the lateral horns, you're gonna have a Horner syndrome. So all of that is there, and that is what we have. So let's just review the whole thing and move on with the next one. Okay, so Syringomyelia, S for S, spinothalamic tract, pain, temperature, out, right? Simple. Spinothalamic, pain, temp, out. Second thing, you can mess up, and one high yield, cape-like distribution, especially with carry one malformation, Carry one was what, in adult or childhood? So adult will come with it, right? Adulthood with carry one, Syringomyelia, no pain. I don't even feel a pain. No temperature, Doc, I was holding a stove. I had no clue that I was holding a stove. I got burned, but I had no clue. No temperature sensation. Oh my God, that's great. That's not good, actually. But we're getting the point, right? Spinothalamic tract, pain, temperature, out, anterior horn, lower motor neuron deficits, in which case what you're going to have is high yield is the intrinsic muscles of hand are going to be atrophied, and flaccid paralysis for sure. And if you were to mess up the lateral side, you're going to have a Horner syndrome. And it is not associated with multiple sclerosis, and it is associated with KRE1, most common in C2 to T9. More than that, most common is going to be your C8 to T1. C8 to T1. And yep, and that's what we have. But other than that, you can also have anything which can cause it. But KRE1 is the one to go for. And that is all we have for Syringomyelia. Let's move on to the next. Alright, now let's talk about anatomy and physiology. So here we have the cells of the nervous system, neurons and non-neuronal glial cells. What are the neurons? Well, neurons are permanent signal transmitting cells of the nervous system composed of dendrites, which receive the input, You have a cell body, you have the axon which send the output. Dendrites and cell bodies can be seen on the Nissl staining, which stains the rough endoplasmic reticulum not present in axons. Markers are high yield, which are neurofilament protein and synaptophysin. Okay, so let's just draw this so that it's easy to recall and to understand. So we have the input. Input is to the dendrites. Through dendrites, we have the cell body, right? And cell bodies are going to send signal to axons, and those axons are going to send the output. So this is all we have. So Nissl staining can be used here within the dendrites or the cell bodies. They have the Nissl staining, which stains the rough endoplasmic reticulum. Okay, now the next line, right side, it says CNS glial cells. What are the CNS glial cells? They are the neuroectoderm, except the microglia, which are derived from mesoderm. PNS glial cells are neural crest ectoderm. Myelin is the multi-layer wrapping of the electrical insulation formed around axons. What does the myelin do? It increases conduction velocity of the transmitter signals, while saltatory conduction of extra potential at the nodes of Ranvier, which is increased sodium channel density. Okay, and the markers were high yield. They are your neurofilament protein and synaptophysins, right? These synaptophysins, they are found in the let's actually write this, change color. Synaptophysins, they are found in the presynaptic vesicles of the neurons, not only neuron but neuroendocrine and neuroectoderm, as they mentioned here. Okay, synaptophysins. So these are all the so the way you can think about how do you know the neurons will have synaptophysins or the NFPs, which is neurofilament proteins. Well, to one of the mnemonic that you can think of is, let me just write that here. That is that the neuron synapses, right? One of the things that you just think about, close eyes, is a neuron. Does it synapse or make a causes muscle contraction? Well, neuron synapses. So neuron synapses, right? So neuron synapses. So it is synaptophysin. Synapse with synaptophysin, and with the neuro, we already know neuron is the simple thing. So neurofilament protein, that's easy to remember. So neurofilament protein, and this is high yield. So markers are super high yield. Okay, and what else? So yeah, that's what we have. Now looking at the next one is the CNS glial cells. We talked about we have the PNS glial cells and CNS glial cells. Glial cell is basically, when we say a glial cell, these are the cells which support wherever they are. If they're in CNS, they're going to support the CNS. If they're in PNS, they will support PNS. They're going to support the neurons in the CNS or the PNS, and they contain all these cells. So CNS supporting cells are these, while the PNS supporting cells are these. So let's talk about first the CNS supporting cells. So in the CNS, we have, first of all, we have the astrocytes. Well, astrocytes, they provide support, but what type of support they provide? They provide physical support. They provide repair, removal of excess neurotransmitters, component of the BBB, which is the blood-brain barrier, glycogen fuel reserve buffer, high yield GFAP positive, GFAP positive, which is gliofibrillary, acid protein, That's the GFAP positive, okay? They are the largest, most abundant glial cells in the CNS. They also have an active role in reactive gliosis in response to neuronal injury. So they play a high yield important role in reactive gliosis, which we will talk about. Reactive gliosis. What is reactive? Let's just look at the definition. What do we mean by reactive gliosis, right? Fancy word. Well, that is just simply saying astrocyte proliferation. So astrocytes, these cells, they are going to proliferate. When they proliferate, we call it reactive gliosis. And when these guys proliferate, they form a scar. It's not called a scab or scar, but it is called, because it's the brain, right? So it's called gliotic scar. High yield. This is a very high yield point. We will talk about that. Gliotic scar because of astrocyte proliferation, and which is the terminology for reactive gliosis. So, in other words, when the neuronal injury occurs, you have reactive gliosis, which is astrocyte would proliferate and form a scar, and that is about it. Okay. Now, one thing that let's actually change color here. So astrocytes, they have a sort of a same role as fibroblasts. Okay, which are outside the CNS, of course, right? So, so one of the things for astrocyte, you have the astrocytomas. Astrocytomas of the cerebellum, they are in the cerebellum in the children. Or other than that, you have the JC virus, which affects specifically astrocytes, JC virus, okay, and with HIV and AIDS. So JC virus, is with HIV and AIDS. They also infect the oligodendrocytes. So JC virus can infect astrocytes, and with HIV and AIDS, they also infect the oligodendrocytes. Yep. And one last thing here, if the neuronal injury is to a level that you cannot cause, you can't fix that, or if neuronal injury leads to death of the neuronal death. This is a very fancy, nice word for that, and that is known as red neuron. Okay. Neuronal death, red neuron, gliotic scar, astrocyte proliferation, GFAP positive, glial gliofibrillary acid protein. Okay, and that is all for the astrocytes. Now let's look at the next one, which is called oligodendrocytes. Let's change color. Oligodendrocytes, or they myelinate the axon in CNS high yield. They include including cranial nerve 2. Okay, and you have a high yield fried egg appearance histologically. Oligodendrocytes. Oligo means fried egg appearance. Instead of calling it oligo, call it olego. Fried egg appearance of those oligodendrocytes. Okay. So each myelinates axon about 30. Predominant type of the glial cells in the white matter, injured in multiple sclerosis. MS messes up with the oligodendrocytes, leukodystrophies, and progressive multifocal leukoencephalopathies. Okay, so these are three diseases which uh, messes up or injures the oligodendrocytes. But high yield major thing is that oligodendrocytes, they myelinate the axons in the CNS. Okay, versus the Schwann cell, which we will see that myelinates the PNS. So oligodendrocytes, high yield is they have the ferritic appearance, and the way we can call that, calling by changing the name of oligodendrocytes to calling it oligodendrocytes, ferritic appearance. Okay, the next one we have is ependymal cells. These ependymal cells, they are ciliated simple columnar glial cells lining the ventricles and central canal of spinal cord. Apical surfaces are covered with cilia, which circulate the CSF, and microvilli, which help CSF resorption. My bad, not resorption, but absorption. Okay. They are specialized ependymal cells, specialized ependymal cells, which are known as choroid plexus. They produce CSF high yield. What produces CSF? They are the specialized ependymal cell which produce the CSF. Okay, and what are these ependymal cells? They are just normal ciliated simple columnar cells which line the ventricles and the canal, and their apical surfaces are covered with cilia. So this is covered with cilia, which circulate the CSF, right? And the microvilli, which helps. There are microvilli, which also helps the absorption of the CSF. And also all about ependymal cells. Now we have the last one here, and that is the microglia. They are activation. They're activated there's an activation in response to tissue damage, that release of inflammatory mediators. Example, nitric oxide, glutamate. They're not readily discernible by nasal stain. Okay, phagocytic high yield. They are phagocytic scavenger cells of the CNS. Microglial are the phagocytic scavenger cells. High yield point is HIV infects microglia, fuses to form multinucleated giant cells in the CNS in HIV associated dementia. Okay, so as we talked about the disease point that we looked at, like the pathology in all of this is going to be astrocyte is seen in JC virus and astrocytoma. Oligodendrocyte is seen in multiple messes up. If there's an injury in multiple sclerosis, leukodystrophies, and progressive multifocal leukoencephalopathy, PMLCs, I guess, but there's a thing for that. But ependymal cells are just they produce the CSF. Specialized ependymal cells produce CSF. Microglial cells are the HIV infects them and makes them multinucleate giant cells and causes HIV-associated dementia. All right, now similar thing for the PNS. PNS supporting cells are as follows. They are the satellite cells. They surround the neuronal cell bodies in the ganglia. Okay, and similar supportive role to astrocytes. What are they surrounding? Neuronal cell bodies in the ganglia. Okay, similar thing as if you look here, this is astrocyte, right? And you have the neuron. This is the neuron, right? And neuron is surrounded by astrocytes, right? So here again, the neuron is surrounded by these cells, which are satellite cells. But this is PNS and this is CNS. So they're saying satellite cells. Just one thing, they surround the cell bodies in the ganglia. Simple. They have the similar supportive role as for the astrocytes. The next important thing is Schwann cells. They myelinate axons in the PNS, including cranial nerve 3, CN3 to cranial nerve 12. 3 to 12, right? And they are high yield. Schwann cells are S100 positive. S100 positive. Okay, each myelin is a single. Again, Shaw one, right? So you can just call it one like this. So they only myelinate one and single axon. That's it, and it is injured in the GB syndrome, Guillain-Barré syndrome. Okay, what is it? So what is oligodendrocyte is associated with MS, multiple sclerosis, while here Schwann cells are associated with GBS, which is Guillain-Barré syndrome. Now just look at this picture here. Let's take a look and see what this picture is about. So we have the neuron right in the middle. We have the neuron in the middle. So around the neck, we said we have the astrocytes in the CNS and the satellite cells in the PNS. We have the rod of Ranvier in both the PNS and CNS, right? And we have oligodendrocytes forming the myelin in the CNS versus Schwann cell forming the myelin in the PNS. Axons are there, and ependymal cells there. Specialized ependymal cell will form the CSF. Schwann cells have S100 positive. Astrocytes will have GFAP positive. Fried egg will be the oligodendrocytes. Okay, and that is all we have for these things. Let's just erase all of this and recall just the four markers and move on with the next one. Okay, so for all the neurons, we're gonna have neuron synapses, synaptophysin, and neurofilament proteins positive, right? For astrocytes, it's gonna be GFAP, which is the gliofibrillary acid protein positive. Oligo is the fried egg appearance because all oligodendrocytes. Ependymal cells specialized will form CSF. Microglial cells, HIV messes them up and causes HIV associated dementia. Satellite cell, they surround the neuron just like astrocytes surround the neuron in the CNS. Schwann cell is S100, myelinate the PNS. And also look at the cranial nerves, high yield, cranial nerve 3 to cranial nerve 12. And the cranial nerve 2 is it is myelinated by the oligodendrocytes. And that is all for this one. Let's move on with the next one. All right. Looking here, we have the neuron action potential, right? So in the neuron action potential, we have the membrane potential on the left side and the time at the bottom. So y-axis and x-axis. What we have is, if you look at the first one, we have a resting membrane potential of negative 75, right? So resting membrane potential membrane is more permeable to potassium than to sodium at rest. Voltage-gated sodium and potassium channels are closed. Looking at this picture here, what do you see? We said the membrane is more permeable to potassium than to sodium at rest. And the voltage gated, these two channels are voltage gated, right? They are all closed. So at point 1, which is at the resting membrane potential at negative 75, you have the permeability of the potassium, but not through the voltage gated, because they're all closed. The sodium channel voltage gated is closed, and the potassium channel voltage gated channel is closed at point 1, right? At resting membrane potential. And the second thing is membrane, point 2 is membrane depolarization occurs. This is the membrane depolarization, right? So as you depolarize, your sodium channel gate opens, that leads to sodium flows inward. If you look here, you have the opening of this channel, sodium channel, and sodium is coming inward, which causes the depolarization of the action potential. Membrane potential depolarizes and goes about close to 40 resting membrane potential, close to 40 membrane potential. Okay. Now the third point is we still have the potassium channel closed, right here, right. Now the third thing is the membrane now starts repolarizing. When the membrane starts repolarizing, the sodium inactivation gate closes at peak potential. So at this point, the sodium inactivation gate is this small thing here. So this inactivation gate closes. So although the sodium channel from top is open, but the inactivation gate closes the channel, right, at the peak at this point, right, and which stops the sodium channel inflow. Potassium activation gate opens. So at this point, the potassium activation gate opens. So this potassium gate opens and potassium flows out. And that is the third one. Now, look at the last one, because now we are at repolarization already occurred. Now we are looking at the last portion, which is the membrane hyperpolarization. It goes a little down than the actual resting membrane potential, so it's hyperpolarized. Why is that? Because potassium activation gates are slow to close. When they're slow to close, it causes excess potassium efflux. So more and more potassium is going out. That causes hyperpolarization. Okay. Voltage gated sodium channel switch back to the resting state. And now here, if you look, it went back to the resting stage in which the channel is just closed. And sodium potassium ATPase pump, restores the ion concentration. And what is that ion concentration? Is that just so you have caused all the potassium to go out of the cell, and you have caused the sodium to come in the cell. So right now, at this point, you just have sodium inside, and potassium outside. But that's not the normal thing. Normally, you have potassium inside and sodium outside. So there has to be a channel, and that channel is sodium potassium ATPase, which throws out the potassium back. It throws out the sodium outside and gets back the potassium inside. So that the next action potential you can follow with the sodium again coming back in and sodium going out. Okay. And that is the sodium potassium ATPase pump. Sodium potassium ATPase pump. Okay, so let's just recall the whole thing and move on to the next. Here, it's a simple thing, neuron action potential. In the neuron action potential, we have the resting membrane potential in which the sodium and the potassium channels are closed, but potassium is still relatively permeable than sodium. Then you have the depolarization. When you open the channel, sodium channel opens, causes depolarization, meaning sodium comes in, causes the depolarization. At its peak, the inactivation gate closes this channel. When the inactivation gate closes its channels, the potassium channels open, and that causes the potassium to go out. When the potassium goes out, it goes out and out till it causes hyperpolarization, which is more than the resting negative 75 action potential, and that is the fact due to the fact that you have these channels close slowly. When these channels close slowly, there's an hyperpolarization. Okay, hyperpolarization. And then finally, you have the sodium potassium ATPase, which fixes all these gradients and gets the cell, gets the neuron ready for the next action potential. And that is all for that. Next one, we have the sensory receptors, high yield. Or sensory receptors, we have the free nerve endings. Receptor types. What are the sensory receptor types? We have free nerve ending, Meissner's corpuscles, Pacinian corpuscles, Merkel discs, and Ruffini corpuscles. Uh, the way you are going to think about all of these are, uh, let's talk about the first one, free nerve endings, right? Free nerve endings are going to be fast. A is fast, C is slow, and then if the mnemonic they have is a delta plane. A delta plane means uh, it's a airline, delta plane. Any airline, like any airline, American airline, delta plane, delta airline plane. So delta plane is fast, but tax is slow. Taxi is slow. So plane is fast and taxi is slow, right? And that is due to the fact that you have, that's a simple thing. Plane is for sure fast and taxi is for sure slow. So C is going to be slow and A delta is going to be fast. Sure, why not? Don't see a problem in this mnemonic. But A delta fast because it's a myelinated fiber, and C taxi slow because it is unmyelinated fiber. So free nerve endings are especially you're looking at myelinated fibers and unmyelinated fibers. The myelinated ones are A, and the unmyelinated are C. And you can just say whichever is myelinated is going to be fast. Location, location, location. All tissues except the cartilage, except the skin. Numerous in skins actually. All tissues except cartilage and islands, but numerous in skin. Sensations are PT, pain, and temperature. Look at the next one. Is the Meissner's corpuscles. Meissner corpuscles, they are large, again myelinated fibers. They adapt quickly. They are present in the hairless skin, like palms, soles, hairless skin, but still you got sensation without the hair, because due to the fact of Meissner's. Okay, one again going back to one of the mnemonic that we did, lesson, right? Lesson had two S's. So lesson is a garlic, which is smooth. So Meissner's is smooth, or you can just say Meissner's smooth. Just remember smooth. Smooth skin, SS, and that is a hairless skin. So who's going to be taking the who is the sensory receptor for smooth skin, which is hairless skin? That is the Meissner's. And then they sense the dynamic, fine, light touch, low frequency vibration, skin indentation. Then you have the Pacinian corpuscles. Pacinian corpuscles, they are large, myelinated fibers. They adapt quickly. They are in the deep skin layers, ligament and joints. Okay, they will sense vibration and pressure. Vibration and pressure. Okay. Then you have this Merkel disc. Merkel disc is all about they will adapt slowly. They're present in the fingertips and superficial skins. Fingertips, superficial skin. Pressure, deep static touch, shapes, edges. You can close eyes and you can hold something with an object which has some shape. You can tell, okay, it's circular or it's rectangular without even looking, because of these Merkel discs at the fingertips. Then you have this Ruffini corpuscles. Ruffini are large myelinated fiber twinned among collagen fiber bundles, adapt slowly. They're also in the fingertips and joints. They would sense the stretch and joint angle change. So one of the things, a mnemonic for this all is, for the top one, you can just think about, for the free nerve ending, you will think about myelinated, not unmyelinated. Myelinated is going to be fast, which is A. and the other guy is going to be slow because it is unmyelinated, which is C. Meissner's SS is smooth uh, skin, which is a hairless skin. Pacinian corpuscles. Pacinian corpuscles is the pace velocity. Pace for pace velocity. So, and that is your vibration, V for velocity, V for vibration, and the P for pressure. Okay. Merkel's desk, instead of calling it disk, call it desk. So when you are on the desk, right, you are always looking at the fingertips, typing, doing something, writing, yeah. So you're looking at the fingertips. Merkel's desk, fingertips, with the deep static touch and the pressure. And the last one is the Ruffini. Ruffini is all about angles, right? Joint angles and all that. So Ruffini is roof angles. Ruffini. When you go to roof, you want to make sure the angles are right. I mean, these are just one mnemonic. If you have a better ones, for sure. These is just some things to keep in mind. If something comes up, you would know a little bit about it, right? So you can recall what they are. And that's pretty much all we have for this one. Let's move on with the next. We have the peripheral nerve. Peripheral nerve, we have endoneurium. Endoneurium is the thin, supportive connective tissue that sheets and supports individual myelinated nerve fiber. May be effective in GB syndrome, GBS, Guillain-Barré syndrome. So we said endoneurium is going to be affected in the GBS. Now let's look at the perineurium. So here's the nerve fiber. First, actually look in the picture here. Here is the nerve fiber. Individual nerve fibers are supported by endoneurium individually. So endoneurium in sheets individual nerve fibers, right? And then on top of that, we have the perineurium, which is there for the blood nerve permeability barrier, P for permeability. It surrounds the fascicles of nerve fibers. So you have a fascicle now, which is surrounded by perineurium. Then you have the last one, which is called epineurium. Well, epineurium is a dense connective tissue that surrounds entire nerve. Epineurium, entire nerve. Okay, which is the fascicles and the blood vessels, everything. Okay, so endo, inner, peri, around, epi, outer. So you already know endo is always endo. Then you have the peri is sort of a new in the middle, and then you have this epineurium. Okay, from center to all the way up. And that is all for the peripheral nerve. Now looking at this response, now this is a high yield one. Neuronal response to the axonal injury. And that is you have, so again, what is the name? Neuronal response. What is the response of a neuron to an axon injury? When the axon's cut up, so looking at this picture here, this is an axon. So when you have the axon getting injured right at this point, what's going to happen to the neuron itself? Okay, now let's look at it. So we have principles here. What first thing we have is called chromatolysis. Chromatolysis is the dispersion of the Nissl substance throughout cytoplasm, not visible on stain. And I'm going to read this and then explain every single thing. So, neuronal cell body reaction reflecting increased protein synthesis in effort to repair the damaged axon, accompanied by round cellular swelling and displacement of the nucleus to the periphery. Okay. The next thing is the axonal retraction. So chromatolysis is right here, and then you have this axonal retraction, and then you have this Wallerian degeneration. So let's actually give you a little hint what we are actually reading. So when you have this at the site of damage, this is the site of damage, right? Let me erase this and get a new color. This is the site of damage. So what happens at the site of damage is that when you have a site of damage, there are two sort of reactions that's going to happen. One is going to be the proximal to the damage, and one is going to be distal to the damage. The one thing which is occurring in the two things that are occurring in the proximal to the site of damage are chromatolysis and axonal retraction, while in the distally to the site of damage is going to be Wallerian degeneration. Okay, and here, let me at the site of damage, at itself, you will form something known as glial scar. And we did talk about what glial scar is when you and we will talk about that as well more here. So now we said when you have a damage proximal to damage, you are going to have chromatolysis. What was chromatolysis? Chromatolysis is you have dispersion of the Nissl substance. Look at here. You have, let's zoom in. You have dispersion of this Nissl substance. You have displacement of the nucleus to the periphery. You have round cellular swelling. All of that is called chromatolysis. Okay. And that's exactly what's written there. On top of that, you also you have a dispersion Nissl substance, you have retraction, you have increase in protein synthesis, also, okay, and accompanied by round swelling and displacement of the nucleus to the periphery. Then the second thing you have is called axonal retraction. Axonal retraction is proximal axon segment retracts and sprouts new protrusions that grow toward other neurons for potential re-innervations. In PNS, the Schwann cells are there. They create a tract that guides axonal regeneration. Okay, so in PNS, who's there? The Schwann cells. They create a tract that guide the axonal regeneration. Okay. And so if you say, okay, if in the PNS you have the Schwann cells which do these, so what about the CNS? If you look here in CNS, let me just in CNS, persistence of this myelin debris and reactive gliosis, which is the glial scar, it prevents axonal regeneration. You know, one of the things we said, CNS, whenever you have a CNS injury, it's never gonna repair, it's not gonna regenerate. But we have seen to the peripheral nerves in the PNS standpoint of view, they do regenerate. And we're like, how? Wow, what is going on? So we led to a conclusion, okay, in CNS, the Schwann cells, they make a track for the axonal regeneration. But in the CNS, because of all of this myelin debris and inflammation, which is reactive gliosis, there is no axonal regeneration in the CNS. And the terminology to that is the Wallerian degeneration, and we talk about that right now. So now the last point here is the Wallerian degeneration. It is at the distal. It is distal to the site of. It is distal axon segment associated with the myelin sheet disintegrates with macrophages, removing debris. In CNS, persistence of this myelin debris and reactive gliosis prevent the axonal regeneration. Okay. So let me erase this and talk about a little more of things. Okay, so what did we learn? So we said uh, we said that so after an axonal injury, so after this site of damage here, we have if this injury is at the PNS level, the Schwann cells will Schwann cells are good because they are the myelin, right? So they will they will degrade the myelin and secrete cytokines. Let's just write that here because that's a new information, which is a high yield information. So in PNS, what's going to happen? These Schwann cells, they will degrade myelin and secrete cytokines. What cytokines? Well, cytokines that will stimulate the macrophages, which leads to the clearance of the debris, and these cytokines leads to trophic factors which regenerate the nerve. Okay, but if the injury was in CNS, oligodendrocytes themselves undergo apoptosis. So instead of oligodendrocytes doing and calling macrophages and also causing a regeneration of the axon, they say, hey, we had enough. We just want to die in peace. So oligodendrocytes go into apoptosis. When they go into apoptosis, and they do not, because they don't release any cytokines, nothing happens, they do not clear debris. When you do not clear the debris, what's going to happen is microglial cells, they have to come in. Microglial cells or microglial cells, right? They will come in small numbers due to blood-brain barrier. So when they come in, they will, because in very small numbers, because of the fact you have a blood-brain barrier, and very small numbers will come in because there is no cytokine produced, no inflammation, nothing, and they will lead to, these microglial cells will lead to persistence of debris that no matter what they do, they will not be able to clear that, right? And that leads to inhibition. This itself, this myelin debris itself would lead to inhibition of new axons. New axons growth via inhibiting factors like neuronal inhibiting factors, myelin associated inhibiting factors. Okay, so they will. So what did I talk about one more time? Neuronal debris will inhibit new axon formations. Why and how? Due to the when you have the persistence of this debris, it leads to there's a myelin association inhibitory factors are present within this myelin. So myelin associated inhibitory factors are going to be present within this debris, which leads to no new axons formation. And on top of that, so this is only one thing. The second thing with this is that you have these astrocytes. They also release the same myelin associated inhibitory factors. Astrocytes also do the same, and astrocytes also proliferate at the site of injury, leading to formation of glial scar. And I will summarize this. Just hold on. I'll summarize all of this. And glial scar will lead to blocks the axonal regeneration. Okay, now let's just summarize. All right, what did we talk about? We said at the site of a very high yield point. Okay, this is very high yield point, super high yield. So let's say this is the injured neuron, right? This is the site of damage. At the site of damage, what's going to happen is, if the damage is in the PNS, we will go into axonal retraction. The axon will retract back, will build itself and form an regeneration of that axon. But if it is in the CNS, we will have Wallerian degeneration. Wallerian degeneration is that the whole thing, the myelin sheath disintegrates, and macrophage will come in and try to remove the debris. Uh, and there will be formation of glial scar by the astrocytes. Now, and there will be no regeneration, prevents axonal regeneration in the CNS. And while in PNS you had axonal regeneration, and the question is why? And the simple answer is that in the CNS, when you have a site of injury, instead the oligodendrocytes do their work and make new myelin and also call macrophages or to clear debris. They undergo themselves, they undergo apoptosis. When they go into apoptosis, you just have the macrophages, which are the microglial cells. They come in, they clear the debris, do nothing else. So debris maintain. Debris maintain leads to myelin-associated inhibitory factors. Myelin-associated inhibitory factors, they lead to release of this. Astrocytes also release this. This leads to no axonal regeneration, or prevents the axonal regeneration. That's one thing. Second thing is astrocytes forms a stump, a scar at the site of injury. A scar is formed, so no connection between the distal part and the proximal part. A scar gets formed here, which is known as the glial scar, which is the proliferation of the astrocytes, which is also known as reactive gliosis, right? A glial scar forms, and that leads to also permanent prevention of the axonal regeneration, leading to permanent blockade of any axons to move forward from this point. And that's only in the CNS. But in the PNS is total different. So let's talk about the whole terminology of the neuron response to axonal injury. You have an axonal injury. First of all, what's going to happen is chromatolysis, which is the round cellular swelling, displacement of nucleus, distortion of the nuclear substance, and increase in protein synthesis. And if it is in the PNS, you will have a axonal retraction, which is basically axon retracts the Schwann cells. They are going to get the cytokines. They release cytokines, which gets all the microglial cell, which clear debris, and not only clear debris, but also Schwann cell will put more myelin in and lead to axonal regeneration. But if it is in the CNS, that's going to cause Wallerian degeneration, which is that you have these CNS oligodendrocytes, which are not going to do anything, but the oligodendrocytes are going to go into apoptosis. When they go into apoptosis, there is no myelin, and on top of that, there is no cytokine release to clear the debris. So this myelin debris, on top of that stump formation by the astrocytes, both lead to prevention of the axonal regeneration. So axon will not be able to regenerate, leading to a stump formation and a permanent damage. And that is all for neuronal response to axonal injury. Let's move on to the next one. And that is neurotransmitters changes with disease, high yield. Okay, here we have the acetylcholine, dopamine, GABA, norepinephrine, and serotonin. Alright, now let's talk about the neurotransmitter changes with disease, high yield. So let's look at the first one, which is acetylcholine. Location of synthesis is the basal nucleus of Maynard forebrain. First, let's talk about the name and the location, which is high yield, okay? So the mnemonic here is going to be so Maynard, right? Maynard is going to be like mayor, right? Mayor. And for Y, you will think about Y for acetylcholine, Maynard for mayor. Or you can think about Maynard and Y for acetylcholine. The only thing that you want to know is, okay, so in the forebrain, it is the acetylcholine and it is the Maynard. Important thing. So it is decreased in Alzheimer's, high yield, in Huntington, an increase in Parkinsonism. Let's look at the second one, is dopamine. For the dopamine, the mnemonic is dope went. Dope went. Well, for the dope went is dopamine, which is dope. Went means ventral tegmentum. And it is also seen in the location of synthesis, also in the substantia nigra. Okay. So this is dope went for ventral tegmentum. It is decreased in depression and Parkinsonism and increased in schizophrenia and Huntington. For the GABA, which is nucleus accumbens, the mnemonic is grab a cucumber, which is GABA accumbens. So grab a cucumber. So you can say GABA, what is it? Cucumber, GABA cucumber. You can just call it GABA cucumber. Or you can do a proper way, say grab a cucumber, which is grab, meaning, let me just write in a proper way so you know what I'm saying, is the GRAB cucumber, which is cucumbens, which is in the basal ganglia. Anxiety you have decreased, and Huntington you have decreased in GABA. GABA is, one more thing, is GABA is a inhibitory neurotransmitter. Norepinephrine, it is the locus ceruleus. Locus ceruleus for norepinephrine, you call it NE, right? Norepinephrine. So new look for norepinephrine, L for locus ceruleus. Okay, and it is increased in anxiety and decreased in depression. Then you have the last one, which is serotonin. Serotonin is the rapha nucleus. And the mnemonic for rapha nucleus is going to be SERAP. S for serotonin and R for rapha nuclei. Okay. And it is decreased in anxiety, decrease in depression, and decrease in Parkinsonism. So let's look at the acetylcholine. For all the Alzheimer disease, all you have is low acetylcholine. So let's just do it this way. For the whole Alzheimer's, all you have is just the low acetylcholine. For schizophrenia, all you have is just high of dopamine in schizophrenia. In anxiety, you have low GABA, which is inhibitory neurotransmitters. You have norepinephrine high, and you have low serotonin. In depression, you have all sorts of everything low. Dopamine low, GABA low, serotonin low. In Huntington, you have low acetylcholine and a low GABA, but high dopamine. And then in Parkinson, you have high acetylcholine, but low dopamine and low serotonin. So these, we will talk about each and every disease, but this is just a overview. But important thing is the first ones we talked about. So let's just go through that. So acetylcholine is the Maynard. It's a basal nucleus of Maynard, and Y for acetylcholine, Maynard. Maynard, Mayor, City of Mayor, Maynard, who knows, something. Get any name and you got this. Dopamine. Dopamine is dope, dope vent. So when you dope, you want to vent it out, right? So dopamine ventral tegmentum. GABA is inhibitory neurotransmitters. Grab a cucumber. GABA is with cucumber. So GABA, nucleus accumbens. Norepinephrine is with new look. New look is norepinephrine. Look for locus coeruleus. Serotonin is SERRAP. SER for serotonin. RAF for rapha nuclei. Okay. We said GABA is an inhibitory neurotransmitter. Glycine as well. Glycine. So GABA is inhibitory neurotransmitters. Glycine is inhibitory neurotransmitters, but in spinal cord. And you have glutamate. Glutamate is it is an excitatory neurotransmitter which acts on the NMDA receptor. Excitatory which acts on NMDA receptor. So what is one thing? If you recall, angel dust, which is phencyclidine. That is the new NMDA receptor antagonist. So here's antagonism of NMDA antagonism. Okay, so yeah, that's all we have for neurotransmitter changes in diseases. Just the whole thing recall. Acetylcholine, Maynard, right? For acetylcholine, which is in the forebrain. Dopamine, dope ventral, dope vent, which is the ventral tegmentum. GABA is the GABA cucumber. You can call it accumbens. Norepinephrine, new look, locus coeruleus. Serotonin, SERRAP, rapha nuclei. All right, let's move on with the next one, which is meninges. So meninges are three membranes that surround and protect the brain and the spinal cord. They're derived from both the neural crest and the mesoderm. Okay, so if you look in this picture, what do we have as for the meninges go? We have just attached to the brain is the pia mater, and then above the pia mater we have the arachnoid matter, and above the arachnoid we have this dura mater. So from brain to all the way up we have a level which is known as PAD. So PAD. So let's actually write brain on the bottom first. So brain, and then you have the PAD, PAD, right? And that's the pia, the arachnoid, and the dura mater. So let's look at what is dura mater. Dura mater is a thick outer layer closest to the skull. What is arachnoid? Arachnoid matter is the middle layer, contains the web-like connections. And what is a pia mater? Pia mater is a thin, fibrous inner layer that firmly adheres to the brain and spinal cord. CSF, where does it flow? CSF flows in the subarachnoid. Let's do a subarachnoid. So between the below the arachnoid is here. It's called subarachnoid space. Look at it between the arachnoid and the pia mater right here. And here what is going on with the pen? PAD, and this is the subarachnoid. This is CSF. Okay. Now epidural. Epi means above. Dural means dura. So above dural space, you have the potential space between the dura and the dura mater and the skull vertebral column containing fat blood vessels, which could be the site of blood collection associated with middle meningeal artery injury. So they're saying above the dura mater, you have an epidural space. Epi above a dural space. That if you mess up or injure the middle meningeal artery, MMA, that's going to give you a lot of fluid collection or blood collection in the epidural space, and that's all about the PM, the meninges. Okay, now let's talk about the blood-brain barrier. So the blood-brain barrier prevents the circulating blood substances, example the bacteria, the drugs, from reaching CSF and CNS. It is formed by four structures, high yield. First, we have the tight junction between the non-fenestrated capillary endothelium. The second is the basement membrane, and third is pericyte. Fourth is astrocyte foot processes. So let's take a look in this picture. We have, first of all, we said we have a tight junction. Here's the tight junction between the non-fenestrated capillary endothelial cells. Second thing, we have a basement membrane. Look here, basement membrane on which these endothelial cells sits on. Third thing is these pericytes. Pericytes are also present. The fourth is the astrocyte foot processes. Astrocyte foot processes are the fourth. Okay. Glucose changing color here. Glucose and amino acid, they cross slowly by carrier mediated transport mechanisms. The nonpolar lipid soluble substances cross rapidly via diffusion. So again, what are we saying? We're saying glucose and amino acids, they would cross slowly because they need a carrier to transport. But the nonpolar or lipid soluble substances, they would cross rapidly because they don't need the carrier transport. They will just diffuse in. Okay, and that's just a normal basic science. Other than that, you have circumventricular organs, which is also known as CVOs. Circumventricular organs, CVOs, which basically just means organs around ventricles. They have organs with circumventricular organs with the fenestrated capillaries, and no blood-brain barriers allow molecules. So there's in CVOs, they have first of all fenestrated capillaries, and they have no BBB, which allows the molecule in the blood to affect the brain function. So whatever in the blood will go out, cause the problem in the brain. Which and what are the CVOs areas? They are the area posterima. Area posterima is one of the area of CVO. What is CVO again? Organs that are around the ventricles. What is the organ? Area posterima. What does it do? It's a vomiting center, right? So vomiting after the chemotherapy. OVLT, which is organum vasculosum lamina terminalis, which is an osmoreceptor. So osmoreceptor is an area posterima, or the neurosecretory products to enter circulation, like neurohypophysin ADH release. Okay, and BBB, blood-brain barrier disruption, for example, in stroke, it's going to cause vasogenic edema. Hyperosmolar agent, for example, mannitol, can disrupt the BBB, which leads to increased permeability of the medications. Okay, so here what we talk about, we said CVOs, they, first of all, they are fenestrated, or they might not have, and no BBB will be there. So anything which is in the blood will affect this area. And one of this area is area posterima. That's why when you give chemotherapy, which is in blood, it goes and affects the brain, affects the area posterima, causes vomiting. And the second area is the OVLT, which is an osmoreceptor. Or you could also think about you not only mess up the brain function, but also you can mess up the neurosecretory products to enter circulation. That ADH can come out and enter circulation, and it does not even have BBB. That's also I yield, and we'll talk about that in an endocrine. That we don't have blood-brain barrier. That's why it detects all the all the levels of the volume levels and also the sodium levels in the when we don't have a BBB, and that causes the release of ADH. And we will talk about that circulation not having the BBB. I think it's called hypophyseal hypoportal circulation, but we will talk about that in an endocrine. The next thing we said, we said not only that with these CVOs, but some things that if the patient undergoes stroke, that it can also mess up all of the BBB, not only the CVOs, and that is going to cause vasogenic edema, with the stroke. And then we said mannitol, which can also mess up the BBB, which would lead to increased permeability of the medications. So all of these. So we need BBB for even glucose and amino acids. If we don't need BBB for any lipid-soluble substance, or in other words, non-polar substance, which are some drugs. Some of the drugs which are high VD, which is the distribution of volume of distribution, they are highly lipid soluble. They go everywhere. So highly lipid soluble, they also go into the brain. And that is what we have. And that is all for the blood-brain barrier. So let's just review the whole thing and move on to the next. Here we said, let me erase all this. Here we said if for the blood-brain barrier, we need 4 things. We need tight junctions, we need basement membrane, we have parasites, and we have astrocyte for processes which form the proper blood-brain barrier. This BBB, we need glucose. Glucose needs a carrier mediated transport to cross this BBB and amino acid. But what does not need BBB is the lipid-soluble substance. They just go through diffusion. CVOs are circumventricular organs, which are, for example, atria postrema and OVLT. They don't have BBB, and atria postrema leads to vomiting, and OVLT is for the osmolar receptors. Neurosecretory products, they don't even have BBB, which, for example, which one in the neurohypophysis, and that causes release of ADH straight into the blood. BBB disruption can occur in stroke and can lead to vasogenic edema. In hyperosmolar agent like mannitol can also disrupt BBB, leads to increased permeability of medications. Now let's review this vomiting center, high yield vomiting centers. Vomiting center is coordinated by NTS, which is, what is NTS? It is nucleus tractus solitarius. Nucleus tractus solitarius in the medulla, which receives the information from chemoreceptors trigger zone. Chemoreceptor trigger zone, CTZ, located within the atria area postrema, pronounced POOK strema. Area postrema is a POOK strema, meaning POOK means vomiting. In the 4th ventricle, GI tract via vagus nerve and vestibular system and CNS. So what are we trying to say here? We are saying that the vomiting center, it is coordinated by NTS, which is in medulla. Now NTS receives information from a couple of areas. Information from, first, the chemoreceptor trigger zone, which is in the area postrema in 4th ventricle. The second is it receives information from the GI tract through vagus nerve, which is CN10. Third, it receives information from vestibular system. And 4th, it receives information from central nervous system. This NTS of the medulla, it is the nucleus. NTS of the medulla in the nucleus. It is the nucleus tractus solitarius of CN7, cranial 7, CN9, and CN10. 7, 9, and 10. So, in other words, what I'm trying to say here is that you have CN9, 7, and 10. So, as I said before, that you have CN10 through this vagus vestibular system. You're looking at CN9 and 7. So NTS in the medulla receives all these information from all these things. Okay, so let's just draw it here so you wouldn't understand what I'm trying to say here. So you have NTS. Excuse me. NTS. You have chemoreceptor trigger zone, and you have also 5 other centers which go and send the signal to the NTS. On top of that, you have vestibular system. You have a GIT and straight up CNS. Okay. So these 5 centers which send to the chemoreceptor trigger zone, and that goes to NTS. And here the vestibular system alone straight up sends to the NTS. GI sends there, and also CNS again sends to the NTS. So why is that important? That is important because these 5 centers are 5 receptors are right here. You have the NK1 receptor, D2, and 5-HT3 receptors, and M1 and H1. So 1, 2, 3, 4, 5. And we will see how that is there. That these guys, they are sending everything to the CTZs, and we will see how. Let's read this first. Okay, we said CTZ and adjacent vomiting centers nuclei receive input through 5 major receptors. Here are the 5 that we wrote. Again, what is it? CTZ, which is the chemoreceptor trigger zone, and adjacent vomiting center nuclei receive input from 5 major receptors: H1, M1, NK1, D2, 5-HT3. In which case you have the 5-HT3, D2, and NK1 and antagonists treat chemotherapy-induced vomiting, and H1N1 antagonists treat motion sickness. H1 antagonists treat hyperemesis gravidarum. So here's what we said. We said we have the NTC. Through that, you have a lot of things coming to the NTC, and I've highlighted that over there, and in which we had the CTZ, which was coming to the NTS. NTS is NTS is a nucleus tractus solitarius. Okay, and NTS also gets the direct straight up supply from the vestibular, from the GI, and from CNS. CTZ, on the other hand, gets its stimulation from 5 receptors, which are NK1, D2, 5-H3, and M1 and H1. One important thing is if we want to, let's just see. I think I messed up a lot of. It should be clean. Okay. Now here, one important thing that you have to just remember is any medication, if you want to give any drug to inhibit vomiting centers, they're all antagonists. They're all antagonists. They're all antagonists. Okay. For example, if you look here, you have antagonism of all of these to treat chemotherapy-induced vomiting, antagonism all of these to treat motion sickness, or antagonism of this to treat hyperemesis gravidarum. So let's look at this picture and then see what are the drugs. In looking at this picture, you have the cerebral cortex, and in cerebral cortex, which is CNS, which is sending signal to NTS, which is nucleus tractus solitarius. Vestibular system is also sending direct signal to the NTS. NGI is sending direct signal to NTS, right? Chemoreceptor trigger zone, CTZ, is also sending direct signal to the NTS, right? But CTZ is getting signals from 5 other receptors, which is dopamine, serotonin, NK1, okay, and then you have the area posterima. Area posterima, which is just beside this NTS, and we look at it within area posterima, and it triggers. So what it is basically also sending the signal to the NTS. So NTS is the major center. If somebody says what is the major center for a vomiting center, is the NTS in the medulla, which is nucleus tractus solitarius. Now look at each one of them quickly, and okay, now let's look at, if somebody has a chemotherapy-induced vomiting, a patient went in for chemotherapy, he's vomiting, we could give 2 things. If it is an acute vomiting, acutely, for example, right away after chemotherapy, you have vomiting, you want to give these 2 drugs, which is 5-HT3 receptor, D2 receptor antagonist. Or if it is a delayed type of a vomiting that is greater than 24 hours, then you will think about NHK1 antagonism, high yield points, okay? And what are the drugs? Let's talk about the drugs since we are here. So the 5-H3 receptor, 5-H3s are going to be your ondansetron, and your granisetron, right? Granisetron, that's your 5-H3, but it's acute, okay? And also in acutely, you can also give D2, right? So what is D2? D2 antagonisms are metoclopramide, and prochlorperazine. So prochlorperazine. So these 2, so this guy is all about 5-HT3 inhibitors, and these guys are all about D2 inhibitors, antagonists, in other words, right? And if you have a delayed vomiting, which is greater than 24 hours, so delayed greater than 24 hours, you can give NK1 antagonist, and that is your fossa prepitant, and aprepitant. Okay. Now let's change color. If someone comes with motion sickness or has a motion sickness and wants to prevent it or get a treatment, what do we have? We have the H1 antagonism and M1 antagonism. H1 antagonism is H1 antagonists are, or H1 inhibitors are promethazine, diphenhydramine, and lastly you have meclizine. And for hyperemesis, let's talk about M1. M1 inhibitors are your scopolamine. It is specific for motion sickness, right? And for hyperemesis gravidarum, changing color, let's change it to black. For hyperemesis gravidarum, you want to give only and only promethazine, the first one. Promethazine. Okay. And what is motion sickness basically? Motion sickness is a patient has nausea, could be vomiting, diaphoresis. These are the signs and symptoms. So now how do we remember which ones are going to be for motion sickness, which one are going to be for chemotherapy induced vomiting? So I have a mnemonic for that, simple. So if it contains 1, so let's just look at here. If it contains 1, if it contains 1 is for motion sickness. Now you say, hey, NK1 is also 1. No. I'm looking at the here. The one here one, not this one. Like H1 and M1. This one. Like subtype of the receptor 1. Okay? That's for the motion sickness. So ones are for motion sickness. And serotonin, dopamine, and K1 antagonists are all for chemotherapy. 5-HT3, which is serotonin type 3 receptor, and D2, dopamine type 2 receptor, they are all for acute. While for greater than 24 hours, like after 24 hours, you get the vomiting, you can give NK1 receptor antagonist, like epi, triptan, and fossa prepitant. And H1 and M1 are for motion sickness, specifically for hyperemesis gravidarum, which is pregnancy-induced vomiting. You want to give H1 blocker, which is promethazine. And that is all. So let's just review the whole thing and move on with the next. So vomiting centers. Okay, vomiting centers is coordinated by NTS, nucleus tractus solitarius, and which receives information from the chemoreceptor trigger zone, located within the area posterima in the fourth ventricle, GI tract, via the vagus nerve, vestibular system, and CNS. Now this CTZ receives input from 5 major receptors: H1, M1, NK1, D2, 5-H3. You have to give all the antagonists to stop the vomiting. For the chemotherapy-induced vomiting, you can give 5-HT3, D2, and NK1, and H1, M1 for the motion sickness. H1 specifically for hyperemesis gravidarum, and that's all for the vomiting centers. Moving on to the sleep physiology. What do we have for the sleep physiology? Sleep physiology occurs in 4 to 6 cycles per night, each lasting 90 minutes and consisting of 2 main stages. We have a non-rapid eye movement, non-REM sleep, and we have a REM sleep, which is rapid eye movement sleep. Duration of REM increases throughout the night or through the night. Okay. Again, what did we said? We said the sleep occurs in 4 to 6 cycles. And each cycle is about 90 minutes. And each of that cycle contains about 2 sleep stages. One is REM and one is non-REM. The REM, slowly by slowly, as you sleep more and more, the REM increases. Now let's look on the right side. We said sleep-wake cycle is regulated by circadian rhythm, which is driven by suprachiasmatic nucleus, SCN, of the hypothalamus. Low light conditions leads to decrease in the suprachiasmatic nucleus activity. It leads to increase in norepinephrine from the superior cervical ganglion, which causes increase in melatonin from the pineal gland. So now important point is low light conditions. Well, we have so much light. We have disruption of the release of norepinephrine. We have the disruption of release of melatonin. We can't sleep at night. Get up early in the morning. It's like 12 a.m. at night. Whole thing messed up. But fix that, yeah, try to fix that. But here, let's get back here. Sleep stages, right? Important. What do we have for the sleep stages? Sleep stages are the percentage of total sleep description and their EEG waveforms. If the patient is awake, if the patient is awake, description is alert, active mental concentration, eyes are open, you're going to have a beta wave, which are going to be high frequency, lowest amplitude. High frequency, lowest amplitude. Eye closed, you will have alpha waves. And alpha waves are these on the right side. So what they mean by high frequency and low amplitude is, high frequency is this. Like it's a high frequency. A low amplitude is, for example, so this is going to be low amplitude and this is high amplitude. So over here is going to be low amplitude. So they are saying high. So when you have a beta wave is seen as you have a high frequency with a low amplitude, meaning it's not that big, it's small. So here's what we have. Low amplitudes. The alpha waves, on the other hand, is just right here, and they haven't defined that, so don't know much. But here the beta is the one that is the active, right? Active, alert. When you have the eyes open, your mind is if you put on an EEG waveform, all the leads and everything, eyes open, you will see beta waves. Eyes closed, you will see alpha waves. Okay. Let's just make a mnemonic. B is an eye. B, eyes are like this, right? Attach them together, that's a B. So when the eyes are open, these two B's are open here, right? So they lead to open eyes, right? So when you open eyes, you have a beta wave. Just keep it to that, right? Open eyes is a beta wave. And whatever the alpha wave is going to be the closed eyes. Now let's look at more important stuff, which is the non-REM sleep. In the non-REM sleep, and the REM sleep is going to come up as well. So non-REM sleep, you have the stages. Stage 1, stage 2, stage N1, which is about 5%, which is light sleep, theta waves. Okay, and N2, which is about 45%. It is the deeper sleep spindles, and K complexes. When bruxism occurs, tooth grinding, N2. So tooth grinding, N2. Tooth grinding, N2. And that is the in N2 tooth grinding. Tooth for two, right? So N2 tooth grinding. So you have a spindle, sleep, spindles, and K complexes. In N3, which is about 25%, is the deep-past non-REM sleep, which is a slow wave sleep. Delta waves, lowest frequency, high amplitude. Okay, look at the low frequency. It's not like this. It is apart. That's low frequency. High amplitude, it is touching the top almost everywhere. So that's the high amplitude, and that's the beta. That's the delta waves. Let me erase this. That's delta waves. Low frequency, highest amplitude. When bedwetting, sleepwalking, night terrors occur, we flee in N3. We flee in N3. So night terrors. So one thing about night terror is that if the patient has a night terror, they will remembers nothing of the dream of the night terror, remembers nothing of the night terror. As compare this with the nightmare. Nightmare, you remember everything. That's a nightmare. Okay, that's one differentiation. But going back up top, what do we have? Is the delta waves is the deepest sleep, with a delta wave, D for deepest sleep, D for delta, and you have bedwetting, sleepwalking, and night terrors. So the mnemonic is we flee in N3. And N3 duration decreases with each sleep cycle. So as you know, the REM sleep increases with sleep cycle, right? So N3 duration decreases with each sleep cycle. Now let's talk about the REM sleep. REM is changing color. REM sleep is about 25% of the sleep. That is, you have a loss of motor tone. It's also known as sleep paralysis. Here you will have increase in oxygen use, brain oxygen use, variable pulse and blood pressure, extraocular movements due to activity of PPRF, which is paramedian pontine reticular formation, which is conjugate gaze center. So what are they trying to say is you will have an extraocular movements due to activity of paramedian pontine reticular formation conjugate gaze center. May serve the memory processing function important. So REM sleep serves as a memory processing function when dreaming. So this is the time when you're dreaming. So REM sleep is when you're dreaming. You have a nightmares when you remember everything, and you have a penile clitoral tumescence occur, which remembers dreams in REM. So R for remember dreams in REM. Okay, dreaming. Here you also have beta waves. Where did we see the beta waves? Now this is very important. Look, beta waves, we said the beta waves are right here. When your eyes are open, you're alert, active, mental concentration is to the max. That's the beta wave, right? But hey, in your REM sleep, you're also in beta wave. Eyes are closed, you're in deep sleep, you are on the beach dreaming, and your mind is thinking, hey, yo, I am alert as I am alert when my eyes are open. Amazing. Amazing. So yeah, that's what we have. Other than that, the changes we have are, let's look at first the factors affecting sleep architecture, and then we will look at some changes. So factors affecting sleep architecture, they are the alcohol, they are the benzodiazepine barbiturates. They all lead to decrease in N3 and REM sleep. Benzodiazepines are useful for sleepwalking and night terrors. So benzos, although they do decrease the REM and N3, but they're useful for sleepwalking. So you give it for sleepwalking and night terrors. For aging, normal aging. Aging causes decrease in, again, N3 and REM, but increase in sleep onset latency and early morning awakening. Increased sleep onset latency with a depression, high yield. What's going to happen to depressed patient? Decrease N3 sleep, increase in REM. Look at this, REM is increased. Decrease in REM latency, repeated nighttime awakenings, early morning awakenings, which is terminal insomnia. Narcolepsy is when you have a decrease in REM latency. And with narcolepsy, is going to be the patient will have a daytime somnolence or daytime sleepiness. Daytime sleepiness, right? And that is what you have. So let's just look at the top portion and see what we have and review the whole thing. Okay, sleep occurs in 4 to 6 cycles per 90 minutes. Every cycle, it consists of two stages, non-REM, REM. And the sleep wake is regulated by circadian rhythm, which is driven by suprachiasmatic nucleus of hypothalamus, which causes release of norepinephrine, which causes release of melatonin from the pineal gland. And for the wake, awake patient is alert, active, mental concentration. You have an eyes open, will have the beta wave. B for the eyes open, right? And that's how you can remember the beta waves. Eye closes, the alpha waves. Non-REM sleeps has 3 stages: N1, N2, and N3. And in N1, you just have a light sleep. You're just falling into sleep. N2, you have a deeper sleep. N3 is the deepest sleep. You are in the deepest sleep. Your mind is just blank, nothing, doing nothing, just sleeping. But then you go into the REM sleep, which is you start dreaming, having the nightmares. You have a penile clitoral tumescence. Okay? And you have this extraocular movements. You have loss of motor tone, which is sleep paralysis. A lot of brain is because it's like active, is using a lot of oxygen at this point. Okay? And your memory processing is also occurring at the REM sleep. Okay? And it is longest. REM is going to be longest in the final third of the night. So REM increases, as we recall, REM increases as the cycles increase. So REM increases, right? So with that, what you're going to have is you will have increased in the final thirds, in the final third of nights. And N3, so this guy is increased, REM is increased, but N3 is decreased as you go with each sleep cycle. Okay. Now, high yield points are going to be this thing, which is in your non-REM, REM, you will have, in non-REM, you're going to have sleepwalk, sleep terror, and sleep eating. So in any case, if you see a patient which has a sleepwalking, sleep terrors, or sleep eating even, it's a non-REM sleep. It's a non-REM sleep. With the REM sleep, it's all about only one thing. It's all about sleep paralysis. Sleep paralysis. Okay, that's one thing. Now, you have as soon as you have a light sleep, N1, which is the theta waves, you can have you can also have here the myoclonic jerk. Sometimes, if you recall, it does happen when you're just trying to sleep, a light sleep, you have a myoclonic jerk. It's called myoclonic jerk. Okay. With the tooth grinding, high yield, tooth grinding is N2, tooth grinding bruxism. With the N3, there are 3 things. You have bedwetting, sleepwalking, and night terrors. Night terrors, high yield, you don't remember anything. It's a terror. You don't remember a thing about it. Okay. N3 is longest in the early half of the sleep, and it decreases as you sleep with each sleep cycle. Okay. With the REM sleep, you have a loss of motor tone, which is voluntary loss of motor tone. Voluntary loss of motor tone that causes sleep paralysis. Voluntary muscle paralysis, basically. Voluntary muscles paralysis means skeletal muscles paralysis. Okay. They have the night mares. They remember everything. Okay. Rapid eye movement. You have a rapid eye movement here in the REM sleep through PBRF, right? And it leads to the beta waves, which are also known as sawtooth appearance. If you look here, you have a sawtooth appearance, right? And that's what we have. Now let's talk about the last one. We said narcolepsy. And try to differentiate between insomnia versus parasomnia. Insomnia is just decreased sleep, which leads to you're tired during day. Parasomnia is undesirable events that occur in sleep and patient can't recall arousal activities. That's parasomnia. So undesirable events that occur in sleep and patient can't recall any arousal activities. Okay. Um, and narcolepsy is just the daytime sleepiness. And that is all for sleep physiology. All right, now let's talk about um, hypothalamus. Hypothalamus, it maintains homeostasis by regulating thirst, water balance, controlling adrenohypophysis, which is anterior pituitary, and neurohypophysis, which is posterior pituitary. Release of hormones produced by the hypothalamus and regulating hunger. Autonomic nervous system, temperature, sexual urges. The mnemonic is very high yield, which is known as tan hats. Tan hats. What is tan hats? Well, tan hat, just think about you have a hat which is tan, it's in the sun, that in the sun you have the hat. Tan hats, right? T for thirst, A for adenohypophysis, N for neurohypophysis, H for hunger, A for autonomic nervous system, T for temperature, S for sexual urges. All of that is done or maintained by hypothalamus. Inputs, excuse me. What are the inputs to the hypothalamus? These areas are not protected by BBB. We talked about it. Inputs, not protected by BBB. OVLT, which is senses the osmolality because it has the osmoreceptors. Area posterima, which is found in the dorsal medulla, responds to emetics, right? Now we have all the nucleus of hypothalamus. We have the lateral nucleus, ventromedial nucleus. So the lateral nucleus, the normal function of the lateral nucleus is to stimulate hunger. Let me do a stimulation here. Stimulate hunger. It is stimulated by lateral nucleus, stimulated by ghrelin, which is inhibited by leptin. So if you know the mnemonic, ghrelin makes you grow. Ghrelin makes you grow, right? So ghrelin stimulates this guy, which is the lateral nucleus, which stimulates hunger, and you eat and eat and eat. And let's say if you have injury now, you injure the lateral nucleus. Now you're gonna be lean and a nice BMI, a nice thin. No need to eat as much as you can, chill as much as you can. You are God gifted, but you're not gonna eat because you're not hungry. Okay, because your hunger nucleus is just out. Okay, so lateral injury makes you lean. The mnemonic is lateral injury makes you lean. L for lateral injury makes you lean. Now VM, ventromedial nucleus, is satiety. It stimulates satiety, which is stimulated by leptin. Leptin acts on this VM nucleus, stimulates satiety. That hey, stop eating. Satiety, stop eating. Ventromedial injury. Now, if you have injury to ventromedial injury, it's going to be very massive. Destruction example occurs in the craniopharyngiomas. Leads to hyperphagia. Eat and eat and eat. Hyperphagia. Okay. So the way, one of the things that you could look for is, look at here, the lateral nucleus. So here's the normal, right? So when you have a lateral nucleus injury, this side is lateral, right? If I say the border, this is lateral and this, the middle part is medial, right? So the lateral is injured. It will cause it will cause lean patient, lean person. While if you have the ventromedial, the mid part was the medial, right? This part was medial. If you have injury to this, I mean, I don't know how you. Well, wait, I have a better way of explaining this. If you have injury to this guy, then it will just lead to massive. But anyway, I mean, remember it any way you like. But what you got to know is lateral nucleus is stimulated by ghrelin and inhibited by leptin, while the ventromedial nucleus or the medial is stimulated by leptin. If you have any injury, the lateral nucleus will make you lean, the ventromedial nucleus will make you very massive. And that's all about these two. Now looking at the next one, anterior and posterior nucleus. Anterior nucleus, the AC, anterior cooling, so it's for the cooling purposes. Okay, it maintains the cooling. Okay, and for the posterior nucleus is about hot pot. Posterior is hot pot. What is hot pot? H for heating, P for posterior. Hot pot, posterior. AC, anterior cooling, hot pot. Hot, posterior. Looking at the next one, we have suprachiasmatic nucleus, circadian rhythm. SCN, suprachiasmatic nucleus, is sun sensing nucleus. You already know that. We don't need to go to mnemonic. That is suprachiasmatic is the circadian rhythm. Circadian rhythm is all about melatonin and all that, sleep, wake cycle. The next one is about your supraoptic and paraventricular nuclei. One thing is look supraoptic and paraventricular, in which case the supraoptic is specific for ADH and paraventricular is specific for oxytocin. Okay, and paraventricular oxytocin. So the mnemonic here is the SADPOX. You don't, I mean, if you want to remember SADPOX, yeah, I mean, it's easy to go for it. SADPOX, like, you have a small pox, everything, you have a SADPOX as well. What is SADPOX? Supraoptic, ADH. So supraoptic, ADH. Paraventricular pox, oxytocin. Okay. And then you have the last one, which is called preoptic nucleus, changing color here. Preoptic nucleus is the thermoregulation sexual behavior, releases GnRH. Now, if you have a failure of the GnRH producing neurons to migrate from the olfactory pit, that is the Kalman syndrome, and I think it's in reproduction, and we will talk about that. And one of the high yield point for Kalman syndrome is you have low GnRH or no GnRH. On top of that, you have you also have anosmia, which is loss of smell. Why loss of smell? Because in the olfactory pit you have a full-on preoptic nucleus, so it just closes all those pits. Now you can't even smell because nothing is going in the olfactory bulb. Everything is just covered, right? And because you're not sending this the neurons back to their hypothalamus, so you're gonna have a low GnRH levels. Okay, we will talk about that in the reproduction. But yeah, that's what we have. One extra thing that is what I have seen is that some talk about is arcuate nucleus. Well, the arcuate nucleus, it secretes dopamine, and you know that dopamine inhibits prolactin secretion, and also it secretes GH, growth hormone, GHRH. Okay. And that's what we have for the arcuate nucleus. So let's just quickly review this and move on to the next. Hypothalamus. Hypothalamus is the tan hats. Tan hats for T for thirst, A for adenohypophysis, neurohypophysis, H for hunger, autonomic nervous system, temperature and sexual urges. Input is inputs areas are not protected by BBB, which are OVLTs and area posterema. You have the lateral nucleus. Lateral nucleus is supposed to make you hungry, but if you have a injury to that, you will be lean. It is stimulated by ghrelin, inhibited by leptin. Ventromedial nucleus. It is the it stimulates satiety, but if you have a VM injury, it's going to cause very massive, like for example in craniopharyngiomas, it leads to hyperphagia. And then you have the anterior nucleus and the posterior nucleus. Anterior for the AC. AC is for cooling. And the posterior is the hot pot. Hot pot is for the heating. And cooling is the parasympathetic. And heating is sympathetic. Suprachiasmatic is all about circadian rhythm from the secretion of this melatonin and all that, circadian rhythm. Then you have the supraoptic and paraventricular. Supraoptic above the optic chiasm, you have the ADH release, and the paraventricular on the side of the paraventricular, you have the oxytocin release. ADH and oxytocin is carried by neurophycins down the axon of the posterior pituitary. So important high yield point is ADH and oxytocin. They are formed in hypothalamus, and they just travel down to the posterior pituitary through neurophycins, where these hormones are stored and released. So they're not formed in the posterior pituitary, while the rest of the anterior pituitary are formed in the anterior pituitary. Okay. Then you have the preoptic. It is the thermoregulation, sexual behavior, and GnRH release. Failure of the GnRH producing cells to migrate is known as the Kallmann syndrome. Arcuate nucleus secretion of the dopamine, which inhibits the prolactin and GHRH secretion. And that is all for hypothalamus. Alright, now let's talk about thalamus. Thalamus is it's a major relay of all ascending sensory. Look at this wording, very high yield. Sensory, everything that is going sensory will be going through thalamus all the way, except one thing, which is olfaction, because that is direct. All the sensory things have to go through. All ascending sensory information except olfaction is going through thalamus. Now let's look at these things. So we have the need the pen, right? VPL, ventral posterior lateral nucleus. The input is spinothalamic and dorsal column, medial and meniscus input. Senses are vibration, pain, pressure, proprioception, light, touch, temperature, right? And destination is going to be your primary somatosensory cortex. Then you have the ventro-posterior medial nucleus. Posterior medial nucleus is the trigeminal and the gustatory pathway for face sensation and taste. High yield. Face and taste. Gustatory. Gustatory means taste. So here's the taste, right? Trigeminal is doing the face sensation. So the gustatory with the taste. The mnemonic here is very pretty makeup goes on the face. VPM, very pretty makeup, VPM, goes on the face. So VPM, again, very pretty makeup goes on face, is the VPM, goes on face. The next is the lateral geniculate nucleus. Lateral geniculate and medial geniculate nucleuses. So lateral one is just doing CN2, optic chiasm, optic tract. So optic nerve, optic chiasm, optic tract, all the way the optic nerve we are looking at, right? And that's the vision. It's going to take that all vision, take it to the primary visual cortex, which is an occipital lobe. Lateral is for light. Lateral for light. Simple. L for light, right? Medial geniculate is taking superior olive and inferior colliculus of tectum, which is hearing. It is hearing to the primary auditory cortex, which is in temporal lobe. Medial is music, music to my ears, right? Medial is music to my ears. So medial is music. Then you have this ventral anterior and ventral lateral, VA, VI, nuclei. They are going to take the input from basal ganglia and the cerebellum. They have the sensation of the motor sensation to the motor cortices. Venus astronauts vow to love moving. Venus astronauts vow to love moving. So again, we're looking at VA, VL, A for anterior, L for lateral, V for ventral. They moving is for motor, right? So motor. So let's just recall this thing. All right, let's do it. This thing, VPL. VPL. It's all about the spinothalamic and dorsal column, which is all these sensations, which will go into the primary somatosensory in the parietal lobe. VPM is all about just the trigeminal, which is the face, and the gustatory, which is the taste. Very pretty makeup goes on the face. Lateral, high yield. Lateral is for light. L for light. M is for music. M for music. Two things are very easy. And the motor is just the ventral. Ventral is the motor. So, you know, when you have a motor vehicle, I mean, I don't know, if you want to remember this mnemonic, you could, but you can say motor vehicle. Motor vehicle. V for ventral. No matter it's a anterior, lateral, but ventral. V for ventral, M for motor. So motors are through vehicle. Motor vehicle. Motor vehicle, right? That's the mnemonic. I mean, if you want to remember this mnemonic, good for it. I mean, go for anything that you like, but try to memorize these things, right? And that is all for thalamus. Actually, one more thing here. Let me just add this a little point here. If you have a destruction of thalamus, destruction of thalamus is normally, not normally, but usually is due to lacunar stroke. And we will talk about that in the lacunar stroke. What is lacunar stroke and all that? When we have a lacunar stroke, it leads to destruction of thalamus, which will give us thalamus syndrome. Thalamic syndrome. What is thalamic syndrome? We will have contralateral sensory loss. High yield is contralateral sensory loss, except smell, and we know that why. And that sensory loss is from face, from arms, from legs. Proprioception, you would have a fault and everything. But if you were to resolve this, if this leads to resolution, let's say, you know, with the lacunar stroke, everything is good now, blood supply is good, everything is great now. With the resolution, you still have a long-term pain. Let me erase this. You will still have a long-term pain, chronic pain on the contralateral side. Pain will be there, but the sensation will be intact. So sensation will come back, but the pain will be there. Sensation will be intact. And that is what you have for the thalamic stroke. Similar to this, we have a hypothalamic. Let me write it in black. We have hypothalamic syndrome. Hypothalamic syndrome. And in which case, all these functions are going to be out. For example, the patient is going to be have obesity. Remember that very massive is there. Obesity is there. Diabetes insipidus will be there. Fatigue because of decrease in cortisol, and also loss of temperature regulation, and all of that will be there. All 10 hats will be gone basically with the hypothalamic syndrome, and that compares with the thalamic syndrome, which is contralateral sensation loss only. But if you were to resolve it, the pain will be there, the sensation will get back. And that is all for thalamus and hypothalamus.